Travikima Kala. Epidemiology and etiology: 4% of cancers of the female reproductive organs, 0.6% of all cancers in the USA. Risk factors: patient-related age, generally advanced age, median age at diagnosis is 70. Diagnosis at younger age is associated with HPV and van lifestyle, cigarette smoking, past medical history, previous or vaginal cancer, previous HPV infection 16, 18, 31, HIV infection, previous cervical or vaginal cancer, hypertension, chronic granulomatous and dystrophic vulvar lesion, women exposed to immunosuppression therapy, pre-invasive lesions, VAN, 2 to 5% progress, Bowen's disease, Paget's disease, erythroplasia. Anatomy: the parts of the vulva are the mons pubis, clitoris, labia majora and minora, and vaginal vestibule. Anteriorly, the vulva blends with the urinary meatus, and posteriorly with the perineum, body, and anus. Bartholin's glands, two small, mucus-secreting glands, are situated within the subcutaneous tissue of the posterior labia majora. The ducts of Bartholin's glands open onto the posterolateral portion of the vestibule. The perineal body is a 3 to 4 cm band of skin that separates the vaginal vestibule from the anus and forms the posterior margin of the vulva. Pathology: 80 to 90% of primary vulvar tumors, SEC tumors of the vestibular glands, Bartholin's glands, often are adenocarcinomas or adenocystic carcinomas, but 30 to 50% of SEC have squamous histology. The remaining, less common histologies include melanoma, basaloid, neuroendocrine carcinoma, Merkel cell carcinoma, and sarcoma. Diagnosis of vulvar cancer requires biopsy of the primary tumor, usually under local anesthesia. Routes of spread: local extension occurs in a stepwise progressive fashion from a distal to proximal direction. Direct involvement of a third of the lower urethra, a third of lower vagina, and or extension to the anus is first. FIGO stage 2. More extensive cases. Further progression proximally involves upper urethral and or vaginal mucosa, bladder mucosa, rectal mucosa, or fixation to bony pelvic structures. FIGO stage of our distant metastasis. Hematogenous metastasis is rare. Risk is 66% if 3 lymph nodes are involved. Routes of spread: regional lymph node metastasis. The overall risk of groin node -10 and 50%, and depends on the presence of one or more of the following factors: size of the primary tumor, depth of invasion, presence of lymphovascular space invasion. Stromal invasion of less than 1 mm leads to nearly 0% of nodal involvement, hence, separately staged as 1A. Stromal invasion of 2 to 5 mm of stromal invasion leads to 8 to 10% chance of nodal involvement. Clitoris can theoretically drain directly to pelvic nodes, but this is rare without inguinofemoral involvement. Overall incidence of pelvic lymph node metastasis is 5%. Routes of spread: regional lymph node metastasis. Deep femoral node involvement without superficial inguinal node metastasis has been reported from clitoris and Bartholin's gland tumors. 25% clinical negative or non-suspicious inguinal nodes are pathologically positive. 65 to 75% clinically palpable, suspicious nodes are pathologically positive. FNA of enlarged groin lymph nodes should be performed to determine nodal involvement. Contralateral spread without ipsilateral nodal involvement occurs in less than 15% of cases. A GOG study also found an unexpectedly high incidence of ipsilateral groin recurrences presumed due to involvement of lymph nodes deep to the cribriform fascia despite negative superficial nodes. Hence, both superficial and deep inguinal nodes need to be dissected. Clinical presentation: vulvar cancer specific symptoms such as pain, spotting or bleeding, discharge, pruritus with advanced disease. Symptoms are due to invasion of adjacent organs, viz., difficulty urinating or defecating, or with intercourse. Presentation with edema of the lower extremities secondary to disease in the groins is rare. DNM, Clinical presentation. 2. Prognostic principles applied based on new knowledge. 1. Size is not a significant factor for survival if the lymph nodes are negative. 2. Number and size of nodal metastasis seem to be prognostic, and these have been separated in the new version of staging. Prognosis. For overall survival, most important factor is presenting stage. Particularly lymph node status. Patients with one groin node involvement have lower risk of recurrence than have those with two or nodes involved. Patients with unilateral groin nodal involvement have better survival than do those with bilateral disease. Positive nodal status reduces survival by 40%. Table 23.6. Most deaths are because of uncontrolled locoregional disease, not distant metastasis. For local control, positive or close surgical margins, most powerful predictor of local vulvar recurrence, margin less than 8 mm, 50% recurrence. Lymphovascular space invasion, deep stromal invasion of greater than 5 mm, large primary tumor size. OS according to extent of disease. Treatment. Surgery. Vulvectomy, wide local excision plus inguinofemoral lymphadenectomy. Indications. The only curative treatment modality, radical in concept but function preserving. It is used for T1 and possibly T2 disease. Consider induction therapy, chemoradiation, for unresectable tumors or potentially mutilating surgery. Facts. Minimum pathological margin of 8 mm around primary tumor is essential to minimize risk of local recurrence. The incision should be carried down to the inferior fascia of the urogenital diaphragm. Inguinal lymph node dissection, LND, including superficial and deep nodes, is usually recommended for all cases with invasive disease of more than 1 mm depth with clinically negative groins. GOG88 study. Contralateral LND is performed if ipsilateral positive lymph nodes are present. Bilateral groins dissection, BGND, needed if central vulvar disease present or for stage 2 and above. Treatment. Radiation therapy. Indications on adjuvant treatment after complete resection to primary tumor and nodal beds. Preoperative or definitive treatment, with chemotherapy. Palliative treatment to primary or metastatic foci. Techniques. EBRT using 3D CRT or IMRT. Interstitial brachytherapy may have a role in extensive lesions where function-preserving surgery not possible. Treatment. Chemotherapy. Indications. Adjuvant treatment after surgery, with EBRT, being studied. Induction or definitive treatment with concurrent EBRT for unresectable disease. Mainstay treatment for palliative therapy. Medications. Anal cancer protocols often used with 5-FU plus MMC or cisplatin plus 5-FU. Clinical trials for managing nodes. Clinical trials for managing nodes. Clinical trials for managing node. Radiation therapy in resectable vulvar cancer. Radiation therapy in resectable vulvar cancer. Radical vulvectomy has been considered sufficient for treatment for vulvar carcinoma, and postoperative trials for adjuvant lymph node. Trials for adjuvant lymph node irradiation. Locally advanced diseases. Locally advanced diseases. Unresectable or inoperable diseases. Comparison of surgery and primary chemoradiation, PCRT, in advanced SEC of vulva. Radiation therapy techniques. Radiation therapy techniques. Field arrangements. Radiation therapy techniques. Field arrangements. Radiation therapy techniques. Field arrangements. Narrow par superior, same as AP field inferior, same as AP field lateral, off femur and match supplemental electron field. Radiation therapy techniques. Field arrangements. Intensity modulated radiation therapy. Intensity modulated radiation therapy. Radiation dose in vulvar cancer treatment. Normal tissue tolerant. Follow-up, lifelong follow-up. Table 23.15, is required for all patients with vulvar cancer treated with curative intent for early detection of tumor recurrence and second primary gynecological malignancies. In addition to recurrent vulvar cancer, there is a higher risk of cervical and anal cancer. First follow-up 4 to 6 weeks after RT. Years 0 to 2 every 3 to 4 months. Years 3 to 5 every 6 months. Years 5 plus annually. Follow-up examinations: history and physical, complete history and physical examination, imaging studies, chest X-ray, if clinically indicated, CT of the abdomen and pelvis, if clinically indicated. Adverse effects after treatment. Thank you all.